Please sit down. Dr. Taiwo has set me up today. I didn't know that that was the plan, but I thank you very sincerely for your kind words. And I also want to thank the Honorable Minister of State for Health, who was kind enough to obey me. I'm humbled. He had some other engagements and was to run away immediately after his remarks. But I begged him to kindly stay behind. And I was surprised when I was taking that initiative. I said, let me make a trial. And he honored my request. Honorable Ministers, I'm very grateful. It all showed that he had the interest of what is happening here and interest of the health of Nigerians. I also want to talk about the CMD of National Hospital, who incidentally, was here quite early. And not only that, is involved in a major program and was to live with the Honorable Minister. Some of you might have seen when we were trying to make some moves, and he agreed to stay back. I'm very grateful. I think that has served as the protocol, but I also would want to recognize the NMA, chairman in FCT, and the director. Thank you very much. I'm meeting you for the first time, but I've always met you in your son, and whom we are well pleased. Thank you very much. And distinguished audience here present, I want to welcome all of you to this meeting. My speech is not going to be very long. I will try as much as possible to keep it short. I always tell people that I'm a professor, I end by talking. So sometimes when you give me an opportunity to talk, and to also talk about what is a passion to me, it's always very difficult. But again, what we also learn is that you should be able to put together your thoughts within the short time. You can't finish saying everything. However, because of the nature of what we want to discuss, I wanted the policy makers to be here. Because, I'm not the cause, the organizers are the cause. They said the way forward. So it means that the policy makers must be with us for us to discuss it. If we discuss without the policy makers, then there is we are not going anywhere, because we can continue to discuss what we have always discussed in our programs, and yet we will not make any impact. I'm particularly impressed with the cardiac care multi-specialist group for this exercise. I'm always excited about anything that has to do with training. As the president of Nigerian Cardiac Society, one of the things that excite me is training and retraining. Anything that has to do with getting people to know more about what we are doing to save more lives. I mean, you can't be everywhere, but in this room, we are going to be affecting the lives of all Nigerians. So we are going to move very fast. Can I move with this? Okay. Okay. We are not going to follow this because I promised I was going to speak for 20 minutes, so I'm going to rush to get to a place that concerns a lot of policy, because that was the promise I made. Okay, so this is a simple definition of what unexpected death, or what we call sudden cardiac death, is. It's either that you witness it, and if that death occurs within an hour, if you witnessed it. But it's also possible you didn't witness death. Many times in our country these days, we report a lot of slump and die. That's the language. Everybody is concerned. And for us in Nigerian Cardiac Society, we are even more concerned. In fact, that's why I'm appearing in this attire, because barely 2 weeks ago, we launched, 2 months ago, we were trying to look at this. And most times when you talk of sudden cardiac death, everybody concentrates on the one you witnessed, but there are also a lot of sudden deaths that occur in people that we don't witness. So how do you describe that? You have seen somebody who is hale and hearty, and nobody saw him or her again, and only to be seen in death. So you may not be able to say exactly from the time whatever started to the time of death. Somebody was seen in the compound, he was talking with people, then he went in to, to sleep and couldn't wake up the following day. So that also falls into the purview of sudden cardiac death. Okay, this is a wide background, but it just shows us a simple slide that I always used to talk about the burden of non-communicable diseases, all around the world. You could see that there are two bars there. One stands for communicable disease. The red one is infectious diseases. The yellow one is non-communicable diseases. All around the world, non-communicable disease is a problem. But you could see that in Africa, everybody used to think that the only problem was, infectious diseases, malaria, TB, HIV. Just 2 days ago was World AIDS Day. So, and you could see the impact that we had in the whole country. But I wonder whether what you do when it is World Hypertension Day, World Heart Day. Meanwhile, obviously from that slide, you could see that the number of people who are dying from cardiovascular diseases, which is the leading cause of non-communicable disease, is at par with people dying from infectious diseases. So I think I need to make that point. This is an artistic picture that I conceptualized over 7 years ago when we started talking about what non-communicable disease is doing in Africa. Nigeria, of course, is not an exception. So that is a picture of Africa, like that woman who is burdened by infectious diseases, malaria, HIV, tuberculosis. And while she's trying to, see if she could breathe a little, then hypertension, diabetes, stroke, heart failure now came on her back. And the only thing the woman could do is to cry with the tears wetting the Atlantic Ocean. And I always, whenever I present, this figure has gone all over the world. And whenever I present this figure, I remind people that from the point where this woman is crying from, which part of Africa is there? That's Nigeria. But see the interesting thing. This sweat, these tears are all dropping. Where is it dropping into? The ocean. I carefully told the artist to make the impression so that the tears will be very clear. But if not, what will be happening to the tears? Dropping into the ocean, and yet nobody sees it. But I pray that after this meeting today, we will all see that non-cardiovascular, non-communicable diseases are a major threat to our existence even as a nation. I don't want to waste time on this, but this is called disability adjusted life years. It's a measure of disease. You want to know which disease do we say is more important than the other. So you put disability adjusted life years, which stands for years lived with disability plus years of life lost to disability. I will always give this simple example. You have a child who is 5 years old, and this child dies from malaria. This is a child who should have lived for maybe 80 years, and the child dies from malaria. It means that through malaria, the malaria has contributed to 75 years lost due to malaria. Do you get that? Now, if this child lived with, for example, cerebral palsy from cerebral malaria, and the child could no longer use his right limb, for example, that child has lived for another maybe 20, 30 years with disability. So all that is attributed to malaria. Does that make some sense? So many years ago, the major contributor to disability adjusted life years was childhood diseases, low birth weight and all that. But what happened in Oh, sorry, this is white background, so I'm not sure if you are seeing everything clearly. But what has happened is that by 2010, hypertension, systolic, is it coming out well? Are you seeing the systolic blood pressure there? Sorry, it's a white background, it's blue for me. Systolic blood pressure remained the leading contributor for disability-adjusted life years. So a man is, 50 years, he develops a stroke, and his right hand could no longer work. This is a man, maybe he's the bursar in a university. So for another 10 years, he lived with a right hand that is not working. So 10 years of life is lived with disability, and then he dies at the age of 70. This is a man who should have lived for 80 years. So another 20 years lost to hypertension. If you put that together, it means that hypertension in that man has cost 30 years lost to disability. And if you look around, even the latest one that is released by Lancet, systolic blood pressure is still the leading contributor to disability-adjusted life years. So I was very happy that the first lecture in this place was on hypertension. Because while you are talking about big things, hypertension, raised blood pressure is still a major killer. If only we can reduce blood pressure, if only we can reduce blood pressure of Nigerians, we will solve lots and lots of problems of mortality. But let us move on. So this is, I think this is on mortality, per, age group that, now I think, okay, we'll just go down to sudden cardiac death. What are the common causes of sudden cardiac death? And of course, you will see that majority of those causes are either acute MI, arrhythmia, and all that. And the underlying problem, check it, starts with hypertension. You move from hypertension to diabetes. These two are major with hypertension. Of course, these are structural heart diseases that can cause sudden cardiac death: ischemic heart disease, non-ischemic cardiomyopathy, valvular heart disease, congenital heart disease. So maybe just congenital heart disease, hypertrophic cardiomyopathy, and arrhythmogenic right ventricular dysplasia. And this other one may be the ones that are congenital and all that, but ischemic heart disease, non-ischemic heart disease, even valvular heart disease, somehow there is a contribution to hypertension, because somebody can have a rheumatic heart disease and the person has been managing the situation. The hemodynamic compromise will be okay. But as soon as hypertension, is superimposed on that heart disease, the destruction on the heart is small. Of course, these are other electrophysiological things that can cause, so how do we prevent? We are looking for way forward, isn't it? So I first put primordial prevention. Primordial prevention starts with, what do you do in the society? You don't even think of those who have the risk. You put the whole society, at a point. I keep telling people that the reason we have continued to have problem of non-communicable disease is because we look at non-communicable disease as a hospital thing. Non-communicable disease is beyond hospital. There must be an interaction between the hospital, the environment, policy making. If not, I keep saying that even the way we construct our routes, do we make provision for where people would take a walk? When we look at our estates in Abuja, for example, what is the provision for simple exercise? Somebody wants to exercise. It's enough for you as a doctor to sit and say exercise 3 times a day. 3 times a week. But you couldn't ask the other question of what is the system that can allow that to happen. So optimize blood pressure control. If you optimize blood pressure control, weight reduction, increase physical activity. There is a major need for physical activity to be introduced everywhere, starting from our school children. I have a lot of interest in preventive medicine, and anything that has to do with preventive medicine excites me. Recently, we are beginning to look at what is happening to physical activity that has to do with school children. We are talking about what hypertension and non-communicable diseases is doing now. What is happening now is a tip of the iceberg. The main time bomb is coming. I tell people that the people who have these cardiovascular diseases now went to schools where the schools have, just one long block like this, and the other place is an empty field for playing. You don't need some of these things that we paint yellow and black and green, for exercise. You don't need all those things. What you need is what? Space. Was that not how our primary school in those days was? The bell goes, and what happens? The children run out to the empty space. You see, these things we create, we use it to even block the little space. For children to do what? The main exercise is not in that thing. It is for children to run out to play. They create football. Even when the ball is not there, you tie, things together and it becomes football. And I say, in those days, children who are coming back from school will be sweating and smelling. But when your children come back from school now, even during break, we are all parents, we are all guilty. We go for parents, teachers association meeting, and we even encourage schools to do computer lessons during break. Which computer? And the children will stay, for hours, pressing the same thing that they press at home. When they come back home, is television. When we were children, one, television were not in every house. Two, even in those houses where you had television, television started by what time? 4 p.m. So the child has time to play. Is that not so? Now, television is every second. You watch whatever you want to watch every second. Our children are not playing. Let me tell us, what we are seeing in non-communicable diseases now is a child's play compared to what we see in the next 30, 40 years. We don't have to say God forbid, because the only way God will forbid it is that we all sit down and do policies that will affect what happens to these children. Otherwise, we are sitting on a keg of gunpowder. Let me tell us, cardiovascular diseases do not start in adults, because that is the impression. You say, let us go, this is something for people who are 40 years and above. It is not true. Adolescent children who will pack all this sugar that we give to them. When we were going to school, primary school, nobody gave us this pack of food. Now, children play less and go to school with pack of food. There must be some legislation, policy against all these things. People don't know. They think, my child is healthy, he's going to school. I will start. Is that not so? But somebody who has never played tennis before, and today he's the MD of GTB, Maitama, and he will come to see you and you say your cholesterol is this is this. Start exercising 3 times. You are wasting your time. It's practically impossible. Do we get that? So I'm taking time to talk about physical activity because these are low-cost measures that can turn things around. The effect, you will not see it immediately. But as an epidemiologist, as somebody who is into public health, there is problem in our country, and unless all of us, sit down and discuss it, what do we do? The people we learn these things from have transformed their own country. Go to UK and everywhere. You build an estate, you create a place for people to play. Is that not so? The transport system is so good and so organized. Look at all of us that came for this meeting. As soon as I drove in here, you see cars. If this meeting was holding in Europe, you are not going to see any, maybe about 5-10 cars. Is that not so? There will be a train station. All of us would have done about 100 or 200 steps to come here. But how many steps have we all done this morning? So we are all in it too. Nobody is exempted. So the earlier we all try to think about what to do to solve our problem, the better for us. Okay, of course, primary prevention. This is now for people who have established cardiovascular disease. So you do risk stratification, and then of course these things are all there for us to look at. Of course, secondary prevention. This is clinical intervention in patients who have survived a cardiac arrest or sustained ventricular tachycardia. When Dr. ISEKO was talking, he talked about somebody who had a cardiac arrest and he put something. So what Dr. ISEKO did was a secondary prevention. Okay. Of course, this is chain of survival. I'm sure some other people will give this lecture about, what to do, early access, early CPR, early defibrillation, and advanced cardiac support. This is still the basic life support. But what I want to do, of course, this is advanced life support. Now, what are efforts in Nigeria? Dr. ISEKO said something when he was talking. He said that why he's doing what he's doing is so that he will tell himself that he has done his own bit. For me, as the president of Nigerian Cardiac Society, I told myself that I'm going to do my own bit. For the past 2 years, we've been working on what do we do to get Nigerians, as we are battling with, trying to do primordial prevention. But in the past 2 years, we've been, inundated in this country with lots and lots of sudden deaths. You want me to list some? Many of them were all either notable figures. And it's so painful, especially with this social media, that what you see is that people will be snapping, happening now, live at Ojuelewa. One man just, I can't understand why that is what we should do. Occasionally I wonder whether maybe the person does not know what to do, or have we lost completely our humanity. So we took it up, but we didn't want to just do anything anyhow. We wanted, I believe so much in structure. So for the past 2 years, Nigerian Cardiac Society have been working on a project. But before I talk about our project, the Honorable Minister is here. I want to talk about what the Ministry of Health has also done. And I want, Dr. ISEKO, Dr. Nua, I would put it to you that while you talked about hypertension, you didn't talk about the guideline. The ministry, we worked with a guideline, which is, how many of us know about the national guideline for control of hypertension? Who knows? Raise your hand. Honorable Minister, sir, would you mind turning back? Would you mind? Just raise your hand if you know, if you have seen the national guideline. 1, 2, 3, 4, 5, 6, 7, 8, 9, 5%. Honorable Minister, the ministry spent a lot in doing this guideline. I was involved for over 5 years. We were working on it, and this guideline was launched on 8th of September. Not just the guideline on hypertension management, tax shifting, tax sharing policy, which I'm also quite interested in. Of course, there were documents, about 6 documents, that was launched, and the interest is that this should be sent all around the country, so that primary care physicians, nurses should have access to this guideline. Honorable Minister, sir, as Nigerian Cardiac Society, one of our contributions is that we are going to publish that guideline in the next 1 or 2 weeks. We are going to send a letter to the ministry. Nigerian Cardiac Society will publish that guideline in Nigerian Journal of Cardiology. And we are going to make it freely available for all health workers in this country. And that is my own contribution. NMA, we are going to send the link of the guideline for hypertension management to NMA. We were invited the day we did the BBL program. We are going to, and our intention is that every doctor in this country must have access to the hypertension management guideline, because this is something that cuts everybody, and that is our own contribution. I'm sure there are nurses here, even the National Association of Nigerian Nurses and Midwives. We are going to send you the link and make this freely available to everybody so that we can actually tackle this major problem that we have. But where do we come in as Nigerian Cardiac Society? We started a program we call BBL, Bring Back to Life. Our thinking, what's
10 minutes more, please.
No, but why? Okay, you wanted to stop me because you know that I'm going to enter into another thing. But I will soon stop. What we want to do in Bring Back to Life is that we want to train all Nigerians, not even the health workers, all Nigerians on how to do basic life support. It was launched about a month ago, and you know, we are happy to say even CardioCare was one of the sponsors of that program. It was launched about a month ago. And the interest, we've developed the framework. The framework is there so that institutions, you know, can train people on how to do basic life support. In the coming year, it is our intention that we are going to train nothing less than 100,000 Nigerians who will not be health workers, school children, university students, secondary school students, market women, you know, people in the armed forces, on how to do CPR. We are developing the manual. All these are all, you know, products that Nigerian Cardiac Society, we've invested a lot. Developing this manual, developing the framework. What we want is that institutions, I've been discussing with, you know, Dr. ISEKO, that even CardioCare can register with Nigerian Cardiac Society and become a provider of, you know, BBL, National Hospital, sir. Can also register with Nigerian Cardiac Society, and then we have the manpower, we have the skill, we have the manual, all manuals to train people who can now go and train university students, you know, people all in our community on how to do CPR. So these are all part of the BBR program. Nigerian Cardiac Society developed this training program framework with certification. So we don't just want to train people, it will have certification. And this certification will be recertified. After 2 years, you will be recertified, you know, and all that. Institutions that meet the necessary requirements can register as a provider. Trainers will be certified and will need to be retrained every 5 years. But the trainers will be recertified every 2 years. Target in the coming year is to train about 100,000 students, officers and men of police, federal road safety, federal fire service, and all that. Okay? Another thing that is also dear to us, you cannot think of, you know, just training people on basic life support. We also have developed a framework of provision of public access defibrillator in all public places in this country. It is only in Nigeria that you will be coming into a very large public place and you won't see a public access defibrillator. Even in African countries. The other day we went to Togo. As you descend into the arrival hall, you will see a public access defibrillator by the side. International conference centers, hotels must have public access defibrillator. So this is also part of what we are doing. It was also launched on that day, you know, at National Open University. And that day, we placed the first public access defibrillator in this country. It's there at the entrance of National Open University. And what we want is that the ministry will support this effort so that this thing will get even into policy and all that. that you cannot have a place that will gather 1,000 people, 2,000, 10,000 people without a public access defibrillator. And it's so easy to do. It doesn't take rocket science. If you train security men, they don't need to be doctors, they don't need to be nurses. Security men should be trained on how to do basic life support. And that alone can save a life. Well, if you click on this, can you, who are those working? Just click on it. I just want to show you the program, and then that will be the end. That is the launching. That we just click on it. Or if you click on it, oh, I'm sorry. That is your computer. If you click on it, it will take you to my computer, but I think we can end it here. But this is just to show us what we did on 16th of October, which the Honorable Minister was, sent, representative to that program. So we want to thank you, sir. On this note, you see why I begged you to stay back, and I'm happy that you stay back. Please extend our warm regards to the Ministry of Health for the support we received, and we want to receive more. We want to move from this to policy that institutions in this country, it has been tried in so many places. In fact, in Netherlands, you cannot graduate from secondary school if you don't have basic life support skills. Can't we do that? Does it take rocket science to do? It's possible, if only we have the will. Thank you very much for your time.
Thank you.